Hi friends, today I'm going to talk about the multi-drug resistant organisms and specifically focus on carbapenem resistant organisms. And we'll try and cover this topic in the next 6 minutes. Now let's start with understanding what does MDRO really mean, and as I said specifically, what does carbapenem resistant organism really mean? Well, it comprises of three different types of resistant patterns. So you've got a carbapenem resistant Enterobacteriaceae, which is E. coli and Klebsiella predominantly. Then you've got some carbapenem resistant pathogens like non-fermentous organisms like Pseudomonas and Acinetobacter. And then you've got colicin breakthrough pathogens like Sternotropomonas and Elizabeth kingae. I think this sort of spectrum of organisms really represents the MDR bugs which we get in our hospital, also what we call as a hospital-acquired infection. So if you really mean CRO is different from CRE. Now, let's break it down a little bit more and understand where India stands in this. So if you look at the epidemiology of Enterobacteriaceae, in India, 70% of the organisms in India from the community actually exhibit ESBL. Now, that's a really, really big number. That means 70% of the organisms which get infected with Enterobacter, people which get infected with Enterobacteriaceae in community will exhibit ESBL resistant patterns. To further sort of understand that, the good thing is that CRE is sort of only 5% or less in our country when it comes from community. However, majority of the CRE is seen in hospital-acquired infection. And various hospitals, various studies have shown a prevalence between 26% to 70%. So that's a big problem for us as far as hospital-acquired infections go. Now, what is really the spectrum? What is the worth of this antimicrobial resistance that we are seeing? So if you look at the critical priority pathogen list for India, we've got these 4 or 5 pathogens which have been listed. So we've got an Enterobacteriaceae group, which is the Klebsiella and the E. coli. And the pattern we are seeing in resistance is carbapenem resistance, tigecycline resistance, as well as colicin resistance. And then we have got a non-fermenting bacteria, which is Acinetobacter and Pseudomonas, which are exhibiting carbapenem as well as colicin resistance. And if you look at the incidence of it, the rate of it, the antimicrobial resistant report of ICMR 2022, which is around 3 years old now, actually showed a resistance pattern of E. coli to be around 18%, Klebsiella around 44%, Acinetobacter 90%, almost 88%, and Pseudomonas around 54%. So this latest guidelines, latest antimicrobial regimes are essentially based on the reports of 2022, which is what we are talking about. And hence, I'm presenting this report to you. What is even more scary is that around 1.27 million deaths are attributed to bacterial antimicrobial resistant bacteria in Southeast Asia and Southern Africa. Now, really, that's a lot of people. That's around 12 lakh people dying every year because of multi-drug resistant organisms, specifically gram-negative. Now, this is sort of a graphical representation of the carbapenem's resistant rates in India. If you look at E. coli, it's around 12% resistant. If you look at Pseudomonas, around 47, Klebsiella, around 57, but Acinetobacter to carbapenem is almost 85% resistant. So we really have very, very few drugs left if we have a problem with Acinetobacter or Klebsiella. Now, if you look at the Ambler classification, which further goes and talks about how these resistant patterns are really divided for us to understand. So if you look at the graphical representation here, the green is good. You can use a narrow spectrum antimicrobial. The orange is ESBL. The dark orange is CAMP, and the red one is carbapenem. So if you look at Ambler A, B, C, and D, Ambler A, essentially the SHV and CTXM represent the community-acquired ESBL and the hospital-acquired ESBL, which you may be seeing. KPC, fortunately, in India is very, very less, almost non-existent, but rest of the resistant patterns are predominantly seen the GES and NDM, which is the Ambler 2 class. Now, Vim was Pseudomonas specific generally, has now been overtaken by NDM. So we see a lot of NDM, of Vim is seen very, very less. AMC, we see a significant amount of AMC still in the country. And of course, OXA 48, which is Ambler class B, and OXA 23, are also quite prevalent in our community, in our hospital-acquired infections. So I think the main ones which we actually deal with right now are the ESBL from community, NDM, AMC, and OXA group. I think these are the 4 groups of organisms that we see in gram-negative bacteria. Now, this is a study which my close friend, Dr. Vasant Nagvekar, and some of the slides, really Dr. Nagvekar has been kind enough to actually share those slides with me. This study was published by him, looking at the pattern in his hospital. And if you look at these 4 total columns out here, one is looking at only OXA48 incidence of resistance. The other is looking at NDM plus OXA48 and then just NDM. And they had around 119 isolates. And if you look at E. coli and Klebsiella in each of these groups, you can see that OXA48 was seen in almost 90%. So though OXA48 was around 33% of all the isolates, Klebsiella exhibited the most OXA48, E. coli was really less. NDM plus OXA48 was seen exclusively in Klebsiella. So Klebsiella, really the difficult organism, OXA48 plus NDM plus OXA48. And then if you come to E. coli, it is almost 26 patients out of the 34, which is roughly around 80% of them were NDM producers, and only few of them were Klebsiella. So isolated NDM with Klebsiella is very rare, but isolated NDM with E. coli is prevalent. Whereas when you come to Klebsiella, you see a combination of OXA48 plus NDM plus OXA48. And then, of course, this is the resistance pattern which we need to think of when we are going to prescribing antibiotics to these patients. Let's further break this down and understand Enterobacteriaceae, Pseudomonas, and Acinetobacter. So if you have a patient who has one of these Enterobacteriaceae in positive, then you will see that almost 80% of them will have either a carbapenem resistant E. coli, and you may have an NDM plus a PBP3 insert. Now, PBP3 insert essentially makes them immune or resistant to your ceftazidime avibactam and aztreonam combination. So you really need to understand what bacteria, what antimicrobial you're going to use for this bacteria. Whereas for Pseudomonas, almost 80% of them are NDM. And as we already discussed, that Acinetobacter has got NDM plus class D OXA23. Similarly, if you come to Klebsiella, you have around half of them which will have NDM plus OXA48. So out of 181, around about 230 isolates, around 181 were either showing NDM or OXA48, and KPC was rarely seen. As I previously mentioned, NDM has taken over the WIM, and in Acinetobacter, colistin resistance is starting to emerge, as well as the PB3 mutation is starting to emerge. And I think we need to be a bit worried about it, because right now, Acinetobacter seems to be quite sensitive to colistin, but at the same time, overuse of that is actually going to cause a lot of problems for us. This is a spreadsheet of the higher antibiotics, or I would say the reserve antibiotics in my hospital. And you can actually see the data which is coming up from my hospital here. If you see organisms in the first column, and then the rest of the columns talk about colistin, polymyxin B, ceftazidime avibactam plus aztreonam, tigecycline, minocycline, sulfamethoxazole, and trimethoprim, and fosfomycin. So for all the NDM producers, the Kleb, E. coli, and Pseudomonas, the colistin, polymyxin B work really well. Whereas if you just take up Klebsiella, it will lead to have a ceftazidime avibactam plus aztreonam combination, but rest of them, the sensitivity is less than half, or only 10%. Whereas for E. coli, if you start thinking of a polymyxin B or a colistin sparing therapy, then you really need to think about what you are going to use, because the organism will be only sensitive to really fosfomycin, which seems to be a very good option to use if you have a very resistant E. coli. Whereas otherwise, you will be forced to use a colistin-based therapy, or you'll be forced to use a combination between either tigecycline or ceftazidime avibactam plus aztreonam. Whereas for Pseudomonas, of course, we know that tigecycline, minocycline, sulfamethoxazole, trimethoprim, and fosfomycin are sort of they have never acted on Pseudomonas. So we are left with only Pseudomonas, which is usually NDM, to be treated with a poly B or a colistin-based therapy only. Whereas for Acinetobacter, again, we mentioned before that you have a good sensitivity to colistin right now and poly B. And there is a reasonable up to 50% sensitivity to minocyclines. If you need to combine something, you could add minocycline to it. The other two organisms, thankfully, are low, Elizabeth and Sterno. But again, their sensitivity is either to Sterno can be treated quite effectively with the combination of ceftazidime, avibactam plus aztreonam, whereas tigecycline, minocycline, and trimethoprim sulfamethoxazole are quite good for that. Elizabeth Kinge, you will be left with either Bactrim or minocycline as a preferred combination. Now, what are the emerging drugs which are seen? So really, if you look at some of the drugs which are coming up and some of the drugs which are available right now, so ceftazidime avibactam, while it may have an activity, I've already shown the problem with it. So you need to sort of combine it with aztreonam to have a synergy there. Meropenem vibrobactam and Meropenem nocabactam seem to be the two which are again emerging out, but we really don't have these available here right now. What we have available is the top 3 plus polymyxin Bs and a combination of maybe high dose meropenem or something. So I hope this video simplifies your understanding about the resistant patterns with carbapenem resistant organisms, and it sort of gives you a little broader understanding of how you will be treating these patients. While newer antibiotics are welcome to be seen, really we don't have a new class of antibiotics. We are just looking at side chain changes and combinations with the Bactam group to sort of come up to our rescue. So guys, thank you very much. I'll be happy to be contacted if you have any concerns. Bye.